As we turn to our final session, taking action, participants respond. We invite you to stay with us as we continue building momentum toward action. A number of meeting participants will showcase their impactful work and tell how they are championing heart disease and stroke prevention. If you would like to participate, please notify us via the Q&A feature, and time permitting, we will get you into the lineup. To begin, I'm going to let him introduce himself, but I'll just say a valued, cherished friend personally, and a great collaborator to the National Forum to tell us about at-home screening for LDLC and LP-little-a.
Well, great. Thanks so much, John. And I'll use maybe 10 seconds of my 2 minutes just to congratulate you and the National Forum team on really another superb annual meeting. Always a great conversation and high impact. So really appreciate all the effort that goes into organizing this and appreciate the opportunity to highlight some of the work being done by the Family Heart Foundation. My name is Hilly Page. I'm the Chief Innovation Officer for the Family Heart Foundation. And we are an organization, a nonprofit patient advocacy organization that supports people with the two most common inherited cholesterol disorders. That's FH and high lipoprotein(a). Lipoprotein(a), as I'm sure you've heard today, is prevalent in 20% of the population, but unfortunately only 1% of individuals are diagnosed because it's not part of a standard lipid panel. And unfortunately, regarding LDL cholesterol, the situation in some ways is even more disappointing in that 41 years after the publication of the first trial showing that lowering LDL cholesterol reduces risk, we are still doing a suboptimal job with awareness, treatment, and control of LDL cholesterol. So with all that in mind, the Family Heart Foundation launched a program called Cholesterol Connect just about a year ago. This offers free at-home testing, finger stick testing for both LDL cholesterol and lipoprotein(a). So anybody in America, regardless of their insurance coverage, can go to cholesterolconnect.org is the website, order a test kit, comes to your house. It's a simple finger stick. And in about a week after you return the test kit, we'll send you a full lipid panel along with your lipoprotein(a). And what's a little different with this program, because sometimes traditional screening programs, there's a lack of follow-up. For this, our Care Navigation Center will reach out to anybody with either a high LDL or a high LP(a) to offer support, educational resources, and connect them with their physician. And so we've sent out over 18,000 test kits so far since launch, and we would invite you to please go ahead and order a test kit at cholesterolconnect.org. Thanks, John.
Thank you, Hilly. Congratulations. A really terrific initiative. And we're proud to be collaborating with the Family Heart Foundation on it. Next, we're going to hear about combating hypertension awareness across Wyoming.
Hi, my name is Kara Beach, and I'm the regional coordinator at the University of Wyoming Center on Aging. The Center on Aging took a unique approach to leverage Wyoming's extensive public library system and distribute self-monitored blood pressure kits throughout the state. This collaborative effort with the Wyoming Department of Health Chronic Disease Prevention Program and the libraries deployed almost 300 kits in all 23 counties and at 67 libraries across the state. The strategy transforms a library into an accessible, non-clinical hub for preventive health, directly addressing the critical need of vast rural state and removing common financial and geographic barriers to blood pressure monitoring. A key success to this program has been engaging individuals who previously neglected monitoring their blood pressure. Since December of 2022, this program has achieved a remarkable 1,521 checkouts statewide. Notably, prior to participation, less than half of the participants had ever monitored their blood pressure before. And this highlights the program's innovation in reaching and activating those in need for early detection and management, making significant gains in understanding the confidence among new blood pressure monitors. We work to overcome the challenge of underdiagnosed hypertension and health disparities In our rural state, there are only 500,000 people, and we are the 10th largest across the nation. But heart disease is the #1 cause of death in Wyoming, and hypertension it leads that, and it's often symptomless, of course, and our risk factors are heart disease and stroke. By placing these kits in accessible community cornerstones, which are our libraries, we're tackling this challenge by ensuring that all the residents, regardless of their socioeconomic status, have access. And I'm out of time, but thank you so much.
Well, congratulations, Kara. A very exciting and innovative program.
Thank you.
Our next speaker will tell us about freestanding blood pressure kiosks that are almost completely across the state of Arkansas.
Thank you, John. I don't know if people can see me, but we'll worry about that later.
Yeah, please go ahead, Dr.
Okay.
Simon.
Yeah, thank you, John, for this opportunity. My name is Bala Simon, a proud Razorback. Though we are down 2-5 this season in football, my organization is the Arkansas Department of Health, a centralized health department which serves over 235,000 Arkansans every year. We took a unique approach to strive towards equity in the state. Arkansas is a small rural state of about 3 million people, and it consistently ranks high among states with the highest heart disease-related deaths. Undiagnosed and uncontrolled blood pressure are leading risk factors for heart disease and stroke deaths in the state. Arkansas is also a poor state where many of our residents cannot afford a blood pressure cuff. Many of our residents cannot afford $30 to $50 to purchase a blood pressure cuff, which is not covered by most insurance plans. Also, most Arkansas residents do not have access to freestanding blood pressure kiosks, such as those seen in Walmart, Walgreens, or CVS in urban states. As a matter of fact, Dollar General and 7-Eleven are more common in rural Arkansas, and they don't have kiosks. So our health department was able to secure CDC public health infrastructure grant to expand access to freestanding blood pressure kiosks in all our local health units. John said almost all. I said 90 of 94 because the last 4 are week-only clinics and they are open only part-time. So we have blood pressure kiosks in all 75 counties in all of our local health units. Availing Monday through Friday, 8 to 4:30. These kiosks offer an easy, accessible way for residents to measure, monitor, and take steps towards better blood pressure control and helps with our equity concern. So thank you for this opportunity, John. Back to you.
Thank you, Bala, and congratulations.
Thank you.
Next, we're going to hear about multiple food is medicine interventions from another cherished friend of the National Forum.
Thanks, John. Hi, everyone. My name's Dr. Marty Mackey, and I'm the president and CEO of Project Angel Heart in Denver, Colorado. We are a statewide nonprofit community-based organization that advances food as medicine principles, primarily nutrition security. We deliver medically tailored meals to those living with severe illness, all up and down the Rocky Mountain range to support health and well-being. We provide about 815,000 meals per year to over 5,000 clients up and down the Rocky Mountain range and across the state. About 40% of our clients face serious cardiovascular disease, primarily COPD, heart failure, and certainly hypertension. And we're actively involved in policy change that supports food as medicine services, as well as screening, testing, referring, nutrition as part of a treatment plan. But as we do a lot in the food as medicine area, I wanted to share just one project that we're involved in that is impacting our state. We are partnering with 3 organizations: Colorado Access, which is one of our managed care, Medicaid managed care organizations; Denver Health, which is a health system that serves mostly Medicare patients in Denver; and the Food Bank of the Rockies. And what we're trying to do is really pair up nutrition security with food security for patients who are discharged after having had an inpatient admission for congestive heart failure or comorbid cardiovascular diseases and type 2 diabetes. And those particular participants in this project received 12 weeks of medically tailored meals, the highest intervention at Food is Medicine. And then they stepped down to medically tailored food boxes from the Food Bank of the Rockies for 6 more months. And what we're really looking at is decreases in inpatient readmissions, emergency department admissions, nursing home admissions, as well as discharge planning systems change. So as a nutrition security organization, we are really excited about the collaboration with a food bank to make sure that people get what they need through Food is Medicine interventions. And we're super excited about the results that we're seeing already in terms of decreased admissions and connecting people to health-related social needs through our approach. I'll stop there.
Well, congratulations, Dr. Mackey.
Thank you,
Exciting
John.
work.
Thanks.
So let's move on to an LDL quality measure update.
Hi, John. Thank you. And thank you to the National Forum for the opportunity. This is Brian Hart. I'm the Executive Director of the National Lipid Association and the Foundation of the National Lipid Association. The NLA is grateful for all of the presentations today because they outline the different levers that are going to help us improve guideline-directed care. And the one that we've selected to really focus on is improving quality measurement. Right now, quality measures with CMS and NCQA focus on the prescription of statins. And what we're hoping to accomplish is to, through a coalition-based approach, achieve improved measurement and management of cholesterol by modifying existing quality measures or scrapping and changing existing quality measures to focus on lipid measurement and LDL control as provided in the most recent versions of the cholesterol guidelines. We've had meetings with CMS and NCQA as of late. Both seem amenable to change, recognizing that there may be some challenge associated with the existing ones. Our target is to see revised measures within the next few years, in the next few cycles. And anybody who's on this call, many of the organizations are already involved in our monthly LDL roundtable to talk about quality measurement, and related projects are invited to join. So if anybody would like to reach out and get involved, please let me know. Thanks, John.
Thank you, Brian. And thank you for your leadership.
Thank you.
Next, we'll hear from one of the National Forum's newest members about the medical fitness model and certified facility standards.
Hello, my name is David Flench. I am the president and CEO of the Medical Fitness Association. So the MFA is a nonprofit professional membership organization that provides industry standards, educational programs, certifications, and networking opportunities to really enhance the operational success and healthcare integration. So a medical fitness center is a medically integrated facility that promotes healthy lifestyle choices as it focuses on the prevention and treatment of lifestyle-related disease, illness, and injury via participation in physical activity, nutrition, chronic disease management programming, and health and wellness education. Medical fitness centers play an essential role in the health and wellness of their communities. So the MFA developed the facility certification program following the publication of the first edition of the MFA Standards and Guidelines. Our certification program is intended to provide a roadmap for facilities so that they can provide safe and effective programs for the people they serve. It also positions a facility as part of the healthcare continuum, establishing a trusted and credible place for healthcare providers to refer their patients with confidence. Several key factors distinguish certified medical fitness centers, including active and regular medical oversight, certified and degreed staff, written policies and procedures concerning user safety and the ability to respond appropriately to all emergencies, disease management and prevention programs, individualized health screening, testing and outcome tracking, and a focus on improving community health. Over the past 15 years, 110 facilities have achieved MFA Medical Fitness Facility certification. These centers have consistently outperformed their peers in nearly all reported outcome data points, both for financial performance and for health measures in their programs. We have our annual conference in a couple of weeks, San Diego, November 4th to 6th. And if anyone would like to attend, please just contact me. I have a few complimentary registrations left. Thank you.
Wow, great offer. David, thank you for the information. Next, we're going to hear about using data and best practices to drive control of LDL, hypertension, and A1C.
Hi there, I'm Hattie Hanley, and I'm showing you, are you able to see my chart in front of you?
We can.
No. You can, okay, great. So a lot of people are not familiar with our success in driving the law of large numbers community-wide in San Diego. I wanted you to know that by inspiring the health systems with best practices, great food, and great colleagues, convening once a month and teaching using data to drive down LDL to less than 100, blood pressure, and A1C according to the NCQA measures, we were able to drop women's acute myocardial infarction hospitalizations by 25% in 4 years. Community-wide, it was 22%. So that also was associated with 86 million in savings, and it was duplicated in 2 different national publications. So now I'd like to turn to talking about our most recent innovation building on this is that we want to flip the script, driving action with data to prevent atherosclerotic events by deploying the best available tools and evidence. The success and innovation that we're proud to share is shifting from precision population health paralleling cancer screening and staging. We convened experts across 6 of the University of California campuses, plus Stanford, Georgetown, and the Air Force for over a year to create a shared decision-making tool to assist primary care teams. We all know primary care is so overwhelmed. So what we did as a group is we, under the leadership of Dr. David Marin, the head of preventive cardiology at Stanford, the group boiled down the AHA and ACC guidelines, which are literally hundreds of pages, and primary care teams are not going to read them.
10 seconds, Hattie.
Oh, okay. So the work was published as a disease staging system in JACC Advances this last year, and we are so grateful to David Marin and to you for inviting us to speak today.
Well, congratulations. The Right Care Initiative is genuinely a high impact organization. And we are pleased to have you share a couple of examples of your work with us. The graphs speak for themselves. So congratulations and thank you. I want to check back real quickly. I believe Julius Hunter has technical difficulties today and is unable to join us, but I just want to check one more time. Dr. Hunter?
He did drop off.
Okay. So next, we're going to hear about your heartbeats for generations.
Good afternoon, John. Thank you. And thank you to the National Forum for having me. My name is Angela Conley, and I am a Hennepin County Commissioner from the great state of Minnesota. Hennepin County, we represent 1.3 million people, and cardiovascular disease is the second largest killer of women specifically in Hennepin County. And after experiencing my own heart attack and surviving it in 2023, I just realized that the symptoms that showed up for me are not the symptoms that I was taught about in school and growing up. So I really wanted to spread the message that symptoms of heart disease and heart attack show up differently for women. And so I authored a board action that invested $1 million into a major marketing campaign and to coordination of care among our clinics within Hennepin County. So what we did was we took out billboards, we were on the sides of buses and talking to residents about, particularly Black and Indigenous women, about how symptoms show up differently, how pain between your shoulder blades, neck pain, pain that radiates along your jaw. These are things I experienced that I never knew were signs of a heart attack. From this work, this is $1 million that is ongoing annually that coordinates care from the time of discharge into support services for women who have experienced heart attacks and to prevent future cardiovascular events. So we're talking about changes to our diet. We have a dedicated webpage, hennepin.us/heartbeats. We are informing folks on how to eat cultural relevant foods by seasoning them differently. We're talking about how lonely it might feel after surviving something as heavy as a heart attack and how to talk to your family about the family history. So we are embarking upon this to save lives, but also through the lens of lived experience. Happy to be a part of this work. Thank you.
Well, Commissioner Conley, thank you very much. It's very exciting work. We're so thankful that you survived your heart attack and that you're channeling the energy from that experience into improving health at the population level. So thank you. And as a former resident of Hennepin County, I'll just say oofta. All right. Thank you all for sharing your impactful work. Dr. Oz said he has hope because there are things we can do to make a difference. Well, you all are making a difference at the national, state, and local levels. And I'm excited because so many of your initiatives are replicable. I mean, libraries in communities all across the country. Look at that opportunity.